Hello everyone, thank you for joining me, Dr. Buzzword, on this tutorial on pleural effusion. We'll be learning about what it is, how to diagnose it, and how to manage it. So let's get started. So what do we mean by pleural effusion? So it is a collection of fluid within the pleural space. This fluid can consist of pus, which we call empyema. If it's blood, we call it a hemothorax, or if it's chyle, it's a chylothorax. We generally categorize pleural effusion as transudative or exudative once we aspirate it. So how do transudative pleural effusion form? They form either due to increased hydrostatic pressure or decreased osmotic or oncotic pressure. Generally, they form bilateral effusion. Causes tend to be congestive heart failure, renal failure, which can lead to fluid overload because the kidneys are not filtering out that much fluid, or constrictive pericarditis. Decreased oncotic pressure tends to be due to hypoalbuminemia, low albumin in the blood. Cause of this can be due to cirrhosis when there is low albumin synthesis, or can be due to nephrotic syndrome where you lose a lot of protein including albumin in the urine, or due to malnutrition, so you have very inadequate protein intake. So how do exudative pleural effusions occur? Well, they occur due to increased capillary permeability or impaired lymphatic drainage within the pleura, and this can be due to either a clot, infection, inflammation, or malignancy. Exudative pleural effusions tend to cause unilateral effusions. Infarctive causes is pulmonary embolism, a clot in the lung, and 90% of pulmonary embolisms tend to cause exudative effusion. Infective causes are the most common, and bacterial pneumonia being the most common type. Tuberculosis can also be another cause. Lung cancer and metastases to the lungs can also cause exudative pleural effusions, and autoimmune conditions such as rheumatoid arthritis or systemic lupus erythematosus or inflammatory conditions such as pancreatitis can all cause exudative pleural effusions. An interesting syndrome that is often tested in exams is Meig's syndrome, which is characterized by a triad of right-sided pleural effusion. This is generally the case, but of course doesn't happen always. Ovarian tumor and ascites. How do we investigate a person who we suspect has a pleural effusion? Generally, when we inspect, we may find reduced chest movement on the side of the effusion. When we palpate around the chest, you might hear a reduced tactile vocal fremitus, and if the effusion is quite large, there may be tracheal deviation from the effusion, which would be a medical emergency. Percussion-wise, you will hear the classic stony dullness, a term that is often used in medical exams, and on listening to the lungs, there will be reduced or even absent breath sounds over the area of effusion. Now, how do we investigate in terms of imaging? Generally speaking, chest x-ray is the first initial investigation we tend to do. It can sometimes also identify the cause of the effusion, such as cardiomegaly, which could suggest a transudative effusion. But generally speaking, as you can see in these two x-rays, in bilateral effusion, there is a blunting of costophrenic angles on both sides of the lungs, whereas on the unilateral effusions, there's only blunting on the one side of the lung. We can also do a thoracic ultrasound scan, which is more sensitive and can also be used to do the pleural tap, i.e. thoracocentesis. And the most sensitive test to do is a CT thorax with contrast, which can show this meniscus-shaped effusion. As the person is lying down on the CT scan, the fluid tends to accumulate on the posterior side of their body. In this case, this is a bilateral pleural effusion. So what do we do after the imaging? We want to aspirate it to see what's in that fluid. We can essentially see how it looks like. If it is clear, or if it's clear, it's generally transudative, although this is not a good way to diagnose it. But we generally send it for biochemistry, especially protein level and lactate dehydrogenase levels, which can be used to determine the Light's criteria. The glucose level. In an infective cause, the glucose level will be a bit low because bacteria love glucose to divide, and the pH level of that fluid. If it's quite low, again, it suggests an anaerobic environment where a lot of lactic acid is being made, and this can be suggestive of empyema. We send this fluid off to culture to see what bug is growing. We also send it for TB as well. And in terms of cytology, how it looks like under the microscope, or what kind of cells it grows, can also be used to aid diagnosis, such as if it's neutrophilia predominant, then it would be more in line with infection or inflammation, whereas if it's a lymphocyte predominant, it could suggest TB or malignancy. So what is Light's criteria? Light's criteria can be used to distinguish between exudative and transudative cause. It predominantly focuses on the protein level and LDH level in the pleural fluid versus the serum Generally speaking, if the protein ratio is greater than 0.5 in the pleural fluid, it is suggestive of exudate cause, because cells contain a lot of protein inside them, so when they die, they release this protein, therefore suggestive of an infection cause of this effusion. LDH, again a marker of cell death. Lactate dehydrogenase is an enzyme stored in many cells inside for anaerobic respiration. When these cells die, a lot of this enzyme is released. If the ratio of the LDH in the pleural fluid is greater than 0.6 compared to the serum LDH, again this is more suggestive of exudate cause. Another way to also determine LDH is checking the pleural fluid LDH is more than 2/3 of the upper limit of the normal serum LDH. Generally speaking, an exudate has a high protein content. They appear cloudy and purulent, and all these are vice versa for transudative effusion. A bus tip to remember is exudative effusions are extremely proteinaceous. Now, let's move on to what an empyema is. An empyema is an accumulation of pus in the pleural space. It's different to a pneumonia, a parapneumonic effusion, which is an effusion secondary to a pneumonia infection. Now, pneumonia can be complicated, and one can develop empyema. Generally, when you aspirate that fluid, the pH is quite low. It's often less than 7.2. The LDH levels are quite high, and the glucose is quite low. Again, this is suggestive of a high anaerobic environment and bacteria growing where there is high uptake of glucose. Empyema is a medical emergency and needs to be treated with IV broad-spectrum antibiotics. We need to insert a chest drain to aspirate the pus, and this is a kind of image you might see in the chest drain. If there is persistent empyema, a surgical intervention might be needed, such as video-assisted thoracoscopic surgery or open thoracotomy, but this will be specialist-driven. Now, how do we manage transudative effusion? The main goal is to treat the underlying cause. If it's heart failure, you treat it with diuretics, or consider fluid restricting the patient and starting them on heart failure medications. If it's due to liver cirrhosis, again, you can give diuretics. Gastro people love their spironolactones, so spironolactone and sometimes lactulose. And you can also consider albumin, because these people also have low albumin in their body. Again, with nephrotic syndrome, you want to treat the renal disease, whether it be having dialysis due to excessive fluid overload or considering albumin. But these decisions, again, are specialist-driven. Generally speaking, a therapeutic thoracentesis is not usually done in transudative effusion because there is an obvious cause that needs to be treated, and if it isn't treated, this effusion is going to return back. Now, how do we manage exudative effusion? So, to treat it, you need to treat the infection first, which is one of the most common causes of exudative effusions. And often you need to put in a chest drain, as there is lung disease. These are some ways you can treat exudative effusion. If it's a parapneumonic effusion, you give IV antibiotics. You don't need to put in a chest drain if the effusions are quite small, because the antibiotics tend to help with the infection and the body will recuperate from it. If the effusion is quite large, then yes, considering a chest drain might be useful. For a malignant pleural effusion, you need a palliative drain for symptom relief of breathlessness. You can also consider giving an indwelling pleural catheter, which is a long-term catheter that can be put inside the chest, which the patient or the relatives can use to drain periodically at home rather than the patient being in hospital. And then inflammatory causes such as for SLE or rheumatoid arthritis, considering immunosuppressants. So I hope you enjoyed this video, and if you did, please make sure to like and subscribe. It will really help me to motivate making more videos. Thank you for watching, and I'll see you next time.